مرحبا كيفكم؟ Dalia, it's not starting here. It's not starting. لا الميوت ولا الفيديو.
لا دكتورة we can hear you أهلين بس we can't see you.
سامعينك سهى سامعينك. سهى سامعيتنا؟
شوي.
هاي الدكتور أحمد مساء الخير.
يا دكتورة مها كيف حالك؟
أهلين.
شو فزعة وطن؟
فزعة. لسه ما بلشوا شكلهم.
لا لسه.
تعال. We'll start in 4 minutes. I think I need to switch because the video is not working anyhow. Oh God.
أوكي يلا.
هذا الأونلاين. Well, actually, okay.
هم يقدموا التوقيت مشان اللي بأمريكا يكون عندهم.
We're gonna start in 3 minutes from now.
Okay.
Not working. Anyway.
I said no. I said no.
It's okay.
So I will start by welcoming everybody. أهلا وسهلا بالجميع. This activity today is part of صحة وطن healthcare initiative activities. The aim of this activity is to raise the awareness regarding COVID-19. Our target audience is the healthcare providers in Jordan, and the second part of the activity will be targeted, it will be open to the public. We'll start with our guest speaker, Dr. Raed Al-Khairi, who is my colleague, and we were med students together. Dr. Ma'moon Al-Bashir will be our moderator, and he will introduce Dr. Raed to us. Dr. Ma'moon, you can start now.
Thank you, Dr. Gould, for the invite first to be part of this interesting meeting. And you've done a great job of assimilating this group of distinguished speakers and panelists, hopefully with the benefit to all. So let me first start by introducing Dr. Raed, who is the chair of infection control of the state of Arkansas, and he's an infectious disease consultant. He's a specialist in Fort Smith, Arkansas, USA, and he's affiliated with Sparks Regional Medical Center, UAMS Medical Center, Baptist Health Services. Dr. Khairi specializes in the diagnosis of management of wide range of infectious diseases in both clinical and hospital setting. He's internal medicine board certified, geriatric medicine board certified, infectious disease board certified, and we couldn't get a better qualified person to talk to us about the topic at hand at the moment, which is sort of an update on the presentation and management of COVID-19. Dr. Raad.
Trying to thank you very much for the invitation. I'm really humbled by this invitation, and I would like to thank Dr. Suha for arranging all this just to be with my beloved family and friends and colleagues, and connecting back is very precious. I'm trying to load the lecture, Suha, so I did the share. Let's see, how do I do this? I'm having already technical issues.
Doctor, the presentation is already opened.
So just open the presentation as you always do.
Let's stop sharing and open the presentation and then start sharing again.
Just the whole screen disappeared. Just 1 second. I'm very sorry regarding that. I have some technical issues.
We started 3 minutes ahead of time. And we're waiting for everybody here else to join.
Okay, sure. It would be easier for me to log out and log in maybe again.
Doctor, can you stop sharing?
You know, I lost the screen that I can share the slides, because I have the up-to-date slides here in new share. When I do a new share, it takes me to select a window or application.
Okay, you can log out and log in again. It's okay.
He's already sharing.
But make sure that the presentation is open before you start sharing.
Maybe that's why. Okay. Okay, here we go. I think we are okay now. Okay, so you have the first slide, right?
Yes, we can see the slide and we can see you as well. So you can go ahead.
Okay, so thank you very much. We're going to talk about COVID-19. This information is valid as of today, October 22nd, 2020. Of course, information can change, and in a week or 2 weeks, this information may not be valid and we may have new literature. Again, thank you very much for Dr. Suha for connecting us and being with our colleagues and friends. COVID-19 is the disease, coronavirus is or SARS-CoV-2 is the virus. And it's a single-stranded envelope RNA belonging to the family Coronaviridae. The infection is zoonotic. It has been, bats has been implicated as a culprit due to the close genome with the SARS that infect bats, and other mammals has been implicated as intermediaries, especially the scaled mammal pangolin as a bridge to jump to human. The WHO declared COVID-19 as a world pandemic. So unfortunately, it's not a disease that's going to disappear. It's going to be in the repertoire that may infect humans regularly. Most important thing when we talk about coronavirus 19 infection is the risk groups. We have to recognize age as a major risk group. 65 years of age is the highest risk group. 65 years of age and older are the highest risk group to acquire the infection, and especially also people with comorbidities. So it's obvious that we have age gradients. So the older you are, the higher you have hospitalization and the higher you have morbidity and mortality. 80% of US deaths happened in patients who are above 65 years of age. The CDC recognized that 94% of deaths are related to at least having one comorbidity present. We see in this graph the COVID-19 hospitalization per 100,000, and it's very clear here. If you look at the gray line, we see the if you compare 65 years and older versus 50 to 64 versus 18 to 49, you see the higher risk of hospitalization, and therefore with hospitalization you get morbidity and mortality. In this graph on your right hand, we have the category 65 years of age versus the other group. And you can see clearly that older patients, they have higher risk of hospitalization. Comorbidities also is another risk factor. Cancer, chronic kidney disease, COPD, immunocompromised status. Obesity is a big one, especially body mass index above 30, serious cardiovascular illness, sickle cell disease, and diabetes mellitus. Most of my patients that I've been seeing, and we see a lot of patients here with COVID-19, are usually obese, diabetic, underlying lung disease, and 65 years of age and more. And those patients, when they come to the ER, even on room air, we will have low threshold thinking of admitting them, actually, because we know that later on they will have more morbidity. Possible increased risk factors, also other risk factors, of course, common sense, make common sense: asthma, cerebrovascular accident, cystic fibrosis, hypertension, immunocompromised status, pregnancy, smoking, thalassemia, type 1 diabetes mellitus, and big one, dementia. Dementia is very important in every city, in every town in the United States. The infection usually starts in nursing homes for some reason. Once you have one resident who is ill at the nursing home, most of the residents or all the patients in the nursing home get sick. You know, I saw that myself. You know, we started with 1 nursing homes, 2 nursing homes, 3 nursing homes. Everybody get admitted, lots of death and morbidity. I don't know if that's related just to the immune system of the geriatric host, or if it's related to other factors, but certainly age and dementia. And this is a study from Ohio Department of Health. You have, they saw how many numbers. You have 70% nursing home patients versus inmates, which is jail inmates, 3%, versus the other population, 27%. And this is nice graph, nice slide. It shows basically the first row shows hospitalization, second row shows death, and you can see the age gradient here. If you're 85 years of age and older, then you become 630 times more likely to die, and 13-fold more likely to be hospitalized. And you can see here the 65 years and older, they have higher risk of death and hospitalization. I'm not a pediatrician, but I'm not sure what happened to the slide with those lines here. The children carry lower risk. 1 to 10 years of age, they are lower risk. At 10 to 18 years of age, they are higher risk than the first group. And the more morbidities you have, such as neurological illness, underlying lung disease, the congenital heart disease, the higher risk to acquire the infection. This is a nice graph here. It shows the morbidities like hypertension, obesity, chronic lung disease, diabetes mellitus, and cardiovascular illness. For some reason, obesity and underlying lung disease make the younger age group, if you see the one in the beige color, have higher risk of hospitalization. So obesity and chronic lung disease makes the younger age group as much susceptible as older age group. And this is also showing here the age discrepancy. The older age group, they have higher risk of acquiring the infection. Transmission of infection, it has been discussed and debated basically whether is this droplet or airborne isolation, or is this respiratory droplets or aerosolized. It's a respiratory droplet illness that requires surgical mask. Nevertheless, in certain circumstances, when you are speaking or singing, or you're in choir, or you're in closed space, the theory is that the infection become more of aerosolization and requires more than droplet isolation precautions. The biggest one is our patients in the hospital, people who are on BiPAP, CPAP, people who are receiving breathing treatment, people who are on Vapotherm, people during autopsy, during intubation. Those are aerosolizing, producing procedures that moves the illness from being droplet isolation to an airborne isolation and more of aerosolization than respiratory droplet. This is an example was published in MMWR, where a choir in the church here, and it's a closed space, and people are close to each other. You can see the amount of probable and confirmed cases that happened several days afterwards. Viral shedding, the asymptomatic shedding is very important. It accounts for 30 to 60%. The shedding starts 1 to 2 days before the symptoms, and the higher viral shedding is in the early in the illness. The question is why widespread and rapid transmission occur is not understood. Of course, the asymptomatic infection, especially in indoor mass gatherings, closed spaces, account for that widespread. And also, when you're in closed spaces and you have aerosol spread, appears to contribute to that. So universal masking, when you cannot establish social distancing, is very important. Stool shedding is very important. Stool shedding was talked about, especially later in the illness, and some scientists or epidemiologists, they are using stool shedding as a way to predict community outbreaks. Incubation period, the mean incubation period is 5 to 6 days. Range is 2 to 12 days. Regarding quarantine, people who are exposed, we like 14 days of observation, recommended to exclude infection. As of patients in general, 10 days have passed since symptoms started and 24 hours with no fever or any respiratory symptoms. Now, viral shedding is an important concept, and it goes hand in hand with equating with severity. Healthy patients, they still shed after 10 to 14 days of illness, but the clinical significance of that is, it doesn't seem to play a role in infection. And that's why when you do the COVID-19 PCR after day number 14, even like 2 weeks, 3 weeks, 4 weeks, it's still positive in certain percentage of patients. And that's because you are detecting dead viral particles. So you do not, we stopped doing COVID-19 PCR after 1 to 2 weeks because this is not the way to stop isolation. In hospitalized and ill patients and immunocompromised patients, they tend to shed longer. So hospitals take 20 or 28 days as a conservative stance used to remove airborne isolation. In our facility, ICU patients, basically we take the number 20 days as basically we stop isolation after 20 days. Or we think 20 days is when we can take them off airborne and do more testing and more aerosolized generating procedure. This slide is very important. It shows the phases of COVID-19 infection. Stage 1 is early infection. It happens from day number 0 to day number 5. It's when you have fever, dry cough, diarrhea, headache. Lab-wise, you have lymphopenia, low lymphocyte count, increased D-dimer, LDH. And then you go from the viral stage, you go between day number 5 to 2 to stage number 2, which is pulmonary phase. And this is where hypoxia starts, and then you have abnormal chest X-ray. After day number 10 is when you go to the hyperinflammation or cytokine storm. And this is where you have ARDS, acute lung injury, and elevation in inflammatory markers, CRP, LDH, interleukin-6, D-dimer, and ferritin. And this shows the same thing, essentially, basically stage 1 viremia, viral phase, then stage 2 is the pulmonary phase, stage 3 is the hyperinflammation phase. So 0 to 5, 5 to 10, 10 to 15. Of course, those are just rough numbers. You know, it's not like, you know, it's a range. Most common symptoms is fever, cough, shortness of breath, fatigue, myalgia. Loss of taste is very important early symptoms. It happened early in the illness. You have to ask about that. Other symptoms: pharyngitis, headache, productive cough. GI symptoms: nausea and vomiting. I would not take it lightly. Some people feel that those people present later on, and those symptoms herald more severe illness later on. They go into more complications. Hemoptysis, chest pain, confusion, cyanosis, and skin changes. One interesting skin changes is the COVID toes. And basically you get like frostbite-like changes in your toes. And I think that's because of the vasoocclusion nature of the illness. You get that, remember this sign. Some people go into cyanosis. For petechial rash, this is a very interesting situation I was in. I have a middle-aged gentleman who has totally different presentation. He came with negative, even COVID. We screened him, he was negative. And later on, we found that he has Staph aureus bacteremia, MSSA, and we treated him. And several weeks later on, he developed this petechial rash, head to toe, started in arms, legs, moved to the trunk, to the neck. And it took us a while. We ruled out leukocytic elastic vasculitis. We ruled out DIC. And then one of the rare manifestations, dermatological manifestation of COVID-19 is petechial rash. He had no pulmonary symptoms, no fever, nothing. We checked him and he was positive. So the disease spectrum, 80% of patients, they don't have severe illness. 20% of patients, they need hospitalization and ICU stay. Most common presentation is pneumonia. You get bilateral infiltrate. It usually happens to older patients, and 50% develop hypoxia by day number 8. And this is where the cytokine storm happens. Your immune system is fighting the virus. You get like inflammation in the lung and bilateral infiltrate. And those people have severe markers such as elevated temperature, respiratory rate, and elevated interleukin-6. And some of them, they go into ARDS and multi-system organ failure. As far as labs, we have elevation in the markers, the dimer, CRP, LDH, troponin, ferritin, and sometimes CPK. So in most COVID-19 patients, we have elevation in those markers. And I usually check them almost on daily basis just to follow the trend and see if the patient symptomatology is matching the lab. Sometimes it doesn't, but it's a way to monitor the patient lab-wise. One lab decreases, which is the lymphocyte count. You get lymphopenia. So that's an important thing. I always order also initially procalcitonin level just to make sure if it's low, it makes it less likely that we have bacterial infection, i.e. less likely pneumonic process. And then I don't have to add brocepin or azithromycin. I just treat COVID-19. And then I, instead of putting more broad spectrum causing resistance later on, because the course will be long. Viral co-infection happen as high as 20%. I personally have not seen it yet. We don't, but I'm sure in the next few weeks when we have the flu, when the flu starts coming, we're gonna start seeing it. So you can have co-infection with influenza A, RSV, influenza B, rhinovirus, etc. And that's gonna be very interesting. We are right now testing for both COVID-19 PCR and influenza A and B with reflex PCR because we have to look for that co-infection. As far as testing, I'm not going to go in details. There's lots of debate and lots of information, but just briefly, COVID-19 PCR has higher sensitivity and specificity, and clinical performance depend on the type and the quality of the specimen and the duration of illness. And you can get false negative from less than 5% all the way to 40%, depending on the technique and the test used. The antigen test is less sensitive than the PCR test. And basically roughly around 70% accuracy, 30% can miss. And I think this is what happened with potentially the infection that happened in the White House. They used this test for anybody who get close to the president. So basically they probably missed that 30%, hypothetically speaking, and that got the infection there. Serologies or antibody, it's the specificity and sensitivity is highly variable. It can take days to weeks to develop. Typically, IgG happen after day number 14. The big problem with antibody testing, and the reason why I don't order it, is that it cross-reactivity with the other coronavirus. There is human coronavirus. There are other coronaviruses that can show false positive test, and then you have the the patient have the false impression that, oh my God, I am immune, let me not put mask and go. That's not true. You may be having false positive antibody. Imaging wise, a CT scan always shows some kind of changes. If you have pulmonary changes, ground glass opacity may evolve into consolidation or ARDS, and usually typically peak at day number 10. And sometimes even it develops before symptoms. In the first picture, we see the ground glass opacity, and usually it's of peripheral, not central, it's of peripheral distribution. The second picture here, we have the crazy paving, which is superimposed inter and intralobular septal thickening, superimposing ground glass opacity. And the third picture, you see the air bronchogram at the periphery. So the distribution usually is peripheral. And this is again peripheral ground glass infiltrate. This is the crazy paving, basically the septal thickening, superimposed ground glass opacity. And just to understand what crazy paving is, you see here the pavement around the pool or toward the house. The architecture seems, they put stones in a different way. They call it crazy paving. And if you compare it with the CT scan, I guess it makes sense. It took me a while to correlate that, but the treatment triage is very important. Should we admit the patient or not? That's a big topic. It's always depend on the physician clinical index of suspicion. If the patient is young on room air, I would send them home and ask him to quarantine. If the patient has comorbidities, chronic respiratory failure, obesity, underlying infection, then you would admit. So basically, it's the decision is the emergency room physician. Regarding treatment, I'm going to go briefly over the treatments. It's much like the influenza, the concept treat early better than treating late. So early in the infection, it's important to treat. Mainly the antiviral agent we have is the IV remdesivir now. The FDA expanded the emergency use authorization on August 2020 for all hospitalized patients. We used to do it wrong, I believe, in last summer. We used to not give it except to patients who are hypoxic on supplemental oxygen. And I think the decision was made because we had shortage in the medicine and it just came in on the market. So we were trying to restrict it. But now we are seeing that when you give it early in the infection, I think the benefit probably is better, and even before requiring oxygen support. Remdesivir is a nucleoside analog. Basically, it inhibits RNA replication, so it stops the cell from being a factory to produce the virus. So it makes sense to start it early. The most important study that with the ACTT for COVID-19 patients treated with remdesivir, it showed the most important fact is that the median time to recovery was reduced by 31%, 11 days versus 15 days. The mortality, though, although was better, 8 versus 11, 6%, but it was shy of being statistically significant. So again, the benefit appears to derive when you give the medicine before the mechanical ventilator, and also the antiviral yield greater benefit when it's used early on. There is a randomized clinical trial in China. It did not show benefit, but it did show significance in mortality. I guess studies are still coming. The other thing is, and this shows the same thing. So the first row here shows critically ill patients. So people who are very ill on ventilator or on ECMO, we give 10-day course of remdesivir. We do 200 milligram IV times 1, then we do 5 days. And then if the patient is still ill, we give it. Some authorities believe that if the patient is not improving beyond day number 5, most likely the medicine will not help and you can stop the medicine. The second row shows the less severe patients, people on room air or requiring supplemental oxygen. We use 5-day course of remdesivir. We use 200 milligram times 1, IV times 1, then 100 milligram IV daily for 5 days. And that's how we do that. There are other antiviral candidates, Kaletra, which is one of the HIV medication, lopinavir, ritonavir, hydroxychloroquine, oseltamivir, all that pan to be not helpful, not useful. We use lots of hydroxychloroquine in the beginning, and that now is not recommended at all. Dexamethasone is one of those, dexamethasone is the most important, I think. It's a cornerstone for the infection. The recovery study showed that dexamethasone 6 milligram IV or PO for 10 days reduced the 28 mortality in hospitalized patients. So, and it's recommended in people with severe COVID-19 requiring oxygen. There is some theory that if you give it early on, you enhance viral replication. So don't give it early on, give it later on in the illness. And this is also debatable, but it's definitely improved mortality. This study shows here, you can see the first column is dexamethasone. The second column shows the usual care, whether you are on oxygen or without oxygen, or if you are on mechanical ventilator, you can see the benefit in mortality percentage-wise if you use dexamethasone versus none. This is the same thing here. What about other corticosteroids? It's also helpful, such as methylprednisolone, hydrocortisone, but studies are ongoing. Tocilizumab, it's a drug that we use for rheumatoid arthritis. It's interleukin-6. It's an agent for CAR T-cell cytokine release. There are anecdotal reports that if you give it early in the infection just before people getting ill, you have rapid improvement within 24 to 48 hours. Unfortunately, there are no randomized clinical trials. Some suggest that it's beneficial if you give it just before ARDS happened, just before intubation. Actually, our local experience with tocilizumab was very disappointing. We had a high percentage of mortality. Mostly people died after we gave them tocilizumab because of secondary bacterial infection. Lots of people end up with staph infection and gram-negative infection. So we stopped using it. And actually, this article, this slide shows an article that was published just yesterday in New England Journal of Medicine. And basically, it's a randomized clinical trial for people with fever, pulmonary infiltrate, or people who need oxygen. It shows that it is not effective for preventing intubation or death in moderately ill hospitalized patients. So I think the tocilizumab is retiring from the agent we use. Interferon B, other countries like in Hong Kong, they tried it with Kaletra and ribavirin. It shows higher, quicker yield for improvement and reduced shield, reduced viral shedding. But interferon, by definition, make you have terrible side effects. And this is the last thing you want to do for somebody with COVID-19 who has myalgias and arthralgias. Anecdotal agents here, we're not going to go through them. They basically, there are lots of clinical trials going on. Monoclonal antibody, it's specific to SARS-CoV-2, is in development. There are two companies, Regeneron and Eli Lilly. Right now, they applied for the FDA to get emergency use authorization, like we do with the convalescent plasma. And this is President Trump's favorite drug. He thinks, we don't know if it contributed to his cure or not, but he was one of the lucky ones who got the Regeneron medicine. We don't have monoclonal antibody because it's not yet approved, but we use convalescent plasma. What is convalescent plasma? Basically, we ask people after they recover by the day of discharge that please, in 2 weeks, call the blood bank and see if you can donate COVID-19 plasma. So they donate the plasma, and we have a pool of plasma. We check our patient blood type and we see if there is a match. And then we get the plasma free of charge delivered for the patient. And we used to give 2 units 24-hour apart. Now it's 1 unit. And this is because there are randomized clinical trial ongoing, and we're getting prelim information. We don't have any definite large randomized clinical trials. The NIH guidelines, it doesn't say that I'm for or against it. But in the past, I used to, all the way from March till last month, I used to fill 30 pages, almost like 20 or 30 pages of papers. It used to be called Expanded Access Program. But since August 23rd, 2020, the FDA gave us emergency use authorization. So basically, we are using it on patients, and I use it early on in the infection too. The idea is that you give the antibody from recovered patient to see if it neutralizes the virus. They used it with other infections in the past, and they used it for, and it did not work with other illnesses. At this point, we are at the time of desperation. We're trying everything to help our patient. Convalescent plasma for COVID-19, it has fewer side effects. It's like any blood transfusion, transmission of infection, HIV, hepatitis B, hepatitis C, allergic reaction, TRALI, transfusion-related acute lung injury, but basically TRALI doesn't happen because they try to get the donation more from male, not female, because female, you have to do screening for HLA antibodies for female who have history of pregnancy in the past, because of the rhesus gene, it produced more acute lung injury or TRALI. Monoclonal antibody, we talked about it, basically that it's still in, studies are still in progress. It's the alternative, it's the purified form of convalescent plasma that we can give the patient early in the infection. Prevention, following common sense, travel restriction, quarantine, school closing, social distancing are all helpful. And when to lift them and or to loosen the restriction is up to the public health officials and politicians, and that open a big Pandora box, basically, and debates in any country. Healthcare workers should follow the guidelines of the CDC. Avoiding sick patients, wash hands with soap and water for 20 seconds, social distancing, universal masking, not touching face, covering your sneeze, and disinfecting frequent touched household objects are all helpful. This is an interesting case that was published by the MMWR. There were two hairstylists. They didn't know that they are COVID-19 positive. They wore the mask consistently at all times, and they had 139 clients. They spent at least 15 minutes with each, and they had 0 case transmission there. And on the opposite side, there was one case where a person was singing in the choir, and then basically they ended up infecting 87% of the attendees because it's a closed place and there was no masking. So avoid groups and stay at least 6 feet and wear face covering. This is an interesting also case that was published by the MMWR. Meat processing plant is very hotbed for COVID-19. Like chicken plant, مسالخ الدجاج, مسالخ اللحمة, you know, or turkey. For some reason, and I live in West Arkansas, we have also in Northwest Arkansas, we have Tyson, we have OK Food. This is where Tyson Food, they have all the chicken plants. The infection for some reason started in those chicken plants and it infected almost everybody. We used to get young people with COVID-19, lots of sick people. And then from there, it moved to the community first, nursing homes, then to the community. For some reason, I think what happened in those processing plant, people work together in close proximity. It's very hard to wear a mask, it's hot. So you should promote distance between those employees. I had to call the health department many times to ask them to go and recheck those meat facilities, and they go and they used to do screening for them and encourage mask wearing and hand hygiene. Complications, it's a big topic. I cannot go over everything in details, but just remember thrombosis. I've seen lots of strokes. I've seen lots of heart attacks, or MI. I've seen lots of PEs. I have a young person who presented only with PE, and the autopsy showed that they were COVID-19 when the patient was asymptomatic. He presented with respiratory failure and coded upon arrival, and the whole manifestation was PE. And then autopsy showed COVID-19 positive. So thrombosis is important. Lots of facilities, and Dr. Abdeen is going to talk about it. Low molecular weight heparin, we use it for prevention. HLH, which is hemophagocytosis or hemophagocytic lymphohistiocytosis, happens post-COVID-19. Basically, this is a very rare and very serious syndrome where you have hyperinflammation in the body. Usually it happens after lymphoma, Epstein-Barr virus, cytomegalovirus. People, they end up with inflammation in the lungs, so they end up with ARDS, they end up with renal failure, they end up with pancytopenia, splenomegaly. It's known to be after, it's rare. Physicians in your all lifetime career, you will see 1 or 2 cases. I've seen 3 cases myself, 2 of them passed. The mortality is 95%. So now we are learning from case report that it can happen post-COVID-19. So keep an eye open for people who present 2 weeks after COVID-19 with pancytopenia and looking very ill. So splenomegaly and hyperretin usually. So you have to look for that syndrome. CNS, also you can have viral encephalitis and secondary infection, bacterial and fungal. The question, can I get reinfected once I catch the infection? Animal models did not support that. human data, the data is heterogeneous. Basically, people who are asymptomatic or people who have a low-level infection, they have lower antibody production. People who are seriously ill, they tend to have 2 to 3 months of immunity. So it doesn't seem that it provides long-lasting immunity. It's almost for 2 to 3 months. There were some changes on our practices, inpatient and outpatient. And inpatient until like August, I used to do on day number 7 and day number 14 on my COVID patient in the ICU or on the floor, repeat testing. As we said, we stopped doing that because we are learning that you can be up to 12-week positive. For critical patients, you can shed the virus longer period. Immunocompromised patients, they shed the virus longer period. So we are extending the precautions to 20 days after symptom onset, or for asymptomatic severely immunocompromised patient, 20 days after their initial positive SARS-CoV-2 diagnosis. Outpatient, we used to say 72 hours from the fever, from the last fever. Now it's 24 hours. And then there is a change from improvement in respiratory symptoms to improvement in symptoms in general, because we have extra pulmonary manifestation. And as we said, immunocompromised patients tend to shed longer. This is just to tell those people who believe that it is just like the flu. It is not just like the flu. It is more serious. You see 2018, 2019, this is the death of flu patients with pneumonia and influenza. And then suddenly you see that big spike this year when you have a percentage of death due to influenza and pneumonia and COVID-19. So we went up quite a bit. Of course, we have a big toll on our community and every community. It's not just the infection. There is increase in anxiety, depression, suicide, drug use, trauma. Very interesting observation. So we have towns or cities that have colleges, and towns that don't have colleges. Towns they do have colleges. They tend to have more cases, and that's because young kids or young students they live together in the dorms, مسكن الطلاب, and then they also don't wear masks because they feel that they are strong enough and they have good immunity. They don't need to wear masks. Unfortunately, those communities, they went up. So we have a city here in our state called Fayetteville. They have probably, I think 80,000 people there. And then you have one school that has probably around 20,000 students. And then the infection went crazy in that college. And then that contributed to the infection in that town. And that brings up a big debate about whether we open schools and close schools, and I'm sure you always hear about that in the media, and it's a big ethical and health hazard discussion. So that's my brief presentation. I tried to jam all the information together. I'm sorry if I missed anything, and about the technical difficulties in the beginning. But I'm going to give Dr. Abdeen now time to talk to you about ICU pearls and managing critical patients.
Well, thank you very much, Dr. Raed. It's a beautiful presentation. It's quite an update. So before we get into the discussion with the distinguished panel, I would like to introduce Dr. Yazan Abdeen, who's currently is the lead critical care physician at HCA Pearland Medical Center, Texas, and he's also the chairman of Critical Care Committee, HCA Pearland Medical Center. Dr. Abdeen is American board certified in internal medicine and critical care medicine, pulmonary medicine, obesity medicine, and he's gonna give us an update about the ICU care of these patients. Dr. Yazan.
Hello, everybody. I would like to be as precise and up to the point as possible, try to give you some critical care pearls in the management. Let me just first share my slides. Just give me 1 second, please. All right. Can we see the slides now?
Yeah.
And you hear me well?
I think everybody's on board, yeah?
Okay, good. So I'd like first to thank Dr. Brian Khair for this informative and really comprehensive lecture that he gave. And from there, I want to take it to some concepts and some practical points that we use for patients who are really sick that comes to the ICU with COVID. I'm going to focus more on the ARDS aspect because, you know, like the sepsis, severe sepsis, septic shock related management, fluid management is kind of similar to the Survival Sepsis Campaign and the guidelines for that. So I would like to focus what's more distinct to COVID than other illnesses. Now, first, I want to bring up this because this is an evolving subject. Basically, new articles have been showing up. One interesting article at July in Lancet Respiratory Medicine, and there's one new article about PEEP and plateau pressure in COVID patients that was published a couple of weeks ago. So it has been describing this COVID because we already, know that COVID causes pneumonia, causes ARDS. Is that the typical ARDS? So they distinguish two types. The first type is, they call it the type L. It's usually the early phases of the ARDS. It's characterized by the low values of elastance, respiratory ventilation perfusion ratio, and recruitability, which means higher compliance. So the clinical part of that is, or the clinical significance is, those patients might tolerate higher tidal volumes, and the PEEP in such cases might be questionable and sometimes be harmful. The other type is called type H, which is basically the typical ARDS. It's high values of elastance, right to left shunting, lung weight, and recruitability. So type H is basically the normal ARDS that we know among patients. And type L, in many situations, can be converted to the late stage, which is the type H. Again, this is a new concept. It's been even discussed at the latest CHEST meeting last week. So I'm not trying to confuse you, but this is something to look forward to because I'm expecting upcoming studies in regards to the management of the vent regarding to those types. Now, I'd like just to present a case. I saw this lady about 3 months ago. So she's 65-year-old. She's have 20-pack year smoking history, hypertension, presented progressive shortness of breath, cough and chest tightness, 4 days duration. Vital signs, she was febrile, a little bit tachypneic, tachycardic. She was hypoxic, 86%, gave her some oxygen the first day, and she improved to 92%. The SARS-CoV-2 PCR was positive. Chest X-ray, I'll show you in a second. She got like bilateral patchy infiltrate, and she was admitted the first day to the medical COVID unit, started on azithromycin, remdesivir, and decadron, and there's her X-ray on presentation, as we see like bilateral fluffy granulous infiltrate in mid-lower zones, which is typical for, COVID with a positive testing. Now, in day 2, we got called. The patient got progressively hypoxic. She got increased work of breathing. We wanted to evaluate the patient, and she was on 80% on non-rebreather mask, 15 liters per minute. So the important question that has been a debate for a while, do we intubate early or should we wait? Now, when we started dealing with patients first in the pandemic at February, March, the recommendation, intubate early, as long as patient needing oxygen more than non-rebreather mask or even more than 6 liters, start considering intubation. We noted that many patients die, and reports from China, from New York, showed about 70% mortality about the intubated patients in ARDS. So that brings us to the point is, should we wait then? The simplest way of dealing with it is, if I'm assessing the patient and patient at bedside, he has altered mental status, hemodynamically unstable, in severe respiratory distress or evolving hypercapnia, I won't delay it. So and it's a clinical judgment at bedside, looking at the patient, how sick they are. So if somebody looks in distress or any of the above, we're just basically, as any patient, we're going to go ahead and intubate. But many of those patients are in that gray zone. They're not as sick, but they're hypoxic. So therefore, all the recommendations right now, considering watchful high flow nasal cannula or BiPAP administration. So most importantly, if we're considering that, we have to have close monitoring for those patients. We can't just basically put them on high flow or BiPAP and leave them, because those patients might get sicker, might end up having respiratory failure and death. So if we're doing this, like with the high flow nasal cannula, I usually put them at 40 liters, 100% start, and can then taper the oxygen. The BiPAP, if I have the AVAP settings, I put them at total volume 450 or 400 to 450, and FiO2 60, 70%, and watch those patients. Now, which is better? High flow nasal cannula, and according to Surviving Systems campaign, they say that it's superior to BiPAP. Other studies show no difference in mortality. There are some studies which makes a lot of sense that said, okay, if the patient has COPD or the patient has CHF, consider doing the non-invasive pulse pressure ventilation like the BiPAP first. So there is no definitive, okay, whether you should use this or that, whatever your patient needs. But most importantly, you need to follow up those patients. So if my patient gets back to any of the above, which is hemodynamic instability, altered mental status, we go ahead and intubate. Or if we want to watch for kind of more objective, we can adopt something like Cleveland Clinic. They use something called the RUX index, which is the saturation to FiO2 to respiratory rate at 2, 6, and 12 hours. So if the number is more than 4.88, there's no need for intubation. Less than 3.85, there's high need for intubation. And I can tell you, since we started doing that, the number of patients that got intubated is way less, and the mortality, and we can tell that the mortality according to the statistics in March per amount of infected patient and now is way less. So for this lady, we watched her, like she wasn't in distress initially, so I put her on high flow nasal cannula. We felt that patient is tiring up, increased work of breathing. She's getting more hypoxic. Okay, let's decide to intubate the patient. So what we're gonna do next? What's the best intubation approach? So most importantly, I like to make this clear for everybody. Safety for yourself and your staff is very important. We all need to take care of more patients. We all have families. We have to protect ourselves. So appropriate PPE, if possible, we have negative pressure room. Try to get all the precautions that you can. Number of medical staff in the room had to be minimized. We don't need 10 people in the room. If a good, physician to intubate, a respiratory therapist, and a nurse, 3 people, 4 people to the max, that's needed. With intubating COVID patients, always try to get the most experienced provider to conduct the procedure. You don't want your first year resident to go ahead and do it because, even right now, since we're waiting till we intubate the patient is already hypoxic by the time we intubate them pretty much, and we cannot do trials on them. And the other thing is it's more exposure and more risk to whoever is going to do the procedure. So try to get somebody who's experienced, one shot, intubate, and that's it. So if possible, we need to provide using the bag valve mask. So the ambu bag, initially, we were not using it much because we were intubating early, as I said, it's at the March time. Right now, since patients are sicker, the one that we do intubate, we tend to use it more. But I just want to highlight one thing because, it did happen to one of the colleagues and, we learned it the hard way. So if I have a patient who's on BiPAP and requiring high pressures, and I give him his paralytic and his sedative agent, and I want to do like the rapid sequence intubation. Always make sure to attach the PEEP valve to your ambu bag, because once you disconnect and you start bagging the patient without the PEEP valve, you'll start seeing your saturation going down crazily. So try to be prepared prior to intubating those people. If it's available, use video laryngoscopy. Like I intubated more than 100 patients COVID, and I never used the conventional one with those because it's safer if it's available. If not, we can use the conventional method. So we went ahead and intubated the patient. Right now, okay, what's the settings that I have to put the patient on? Tidal volumes, till now, we try to stick to the Society of Critical Care Medicine and ARDS network guidelines. We start with the low volume ventilation, protective lung ventilation, usually 4 to 8. We start with 6, estimately about 400 ml in a 70 kg male. It's very important to note that it's the predicted body weight, not the actual body weight. So there's a calculation that you have to do and get your tidal volume accordingly. Now you're gonna go do your respiratory rate. We usually start with 16 to 20. We adjust it to according to the ABGs to get the pH more than 7.2. I usually go up to 34. Now, in terms of the pH, if the patient is profoundly hypercapnic after optimizing the respiratory rate and I'm at 6, and your plateau pressure is less than 30, you might consider going up to 8 ml per kg in your tidal volume. So that's one of the situation, or if there is dysynchrony in your vent, you might consider that as well. But the goal is to start first with the lower volume. We have to always to maintain that plateau airway pressure less than 30. The PEEP so far is strongly recommended by all the societies, Critical Care Medicine, ARDSnet, ATS. But very important, when we apply the PEEP, because we've seen it a lot, many patients with COVID, they have a tendency to have pneumothorax or pneumomediastinum pretty high. The percentage we are seeing it, like we're seeing tremendous amount of cases. So we want to try to play it safe. Having this kind of new pathological concept of the L and H type, and we want to try to apply the PEEP safely, we try to do this driving pressure method. I'm trying to simplify it. Now, if I do have a patient, I'm having him on the setting PEEP of 10, and I measured his plateau pressure bedside is 20. If I want to raise it by 5, instead of 10, I'm going to go to 15. If my plateau pressure went from 20 to 30, that means my driving pressure is more. That means I am adding harm to the lung by adding more pressure. If I'm achieving recruitment, the volume should be, or the plateau pressure should be the same or sometimes less. So if you want to try to do this increase in the PEEP, try to watch the plateau pressure and do it safely to recruit the lung and not to add harm to it. So what about proning? I mentioned first the self-proning, which basically new studies has been published about even in patients who are not intubated. It did show improved oxygenation and decreased risk of intubation at the hospital. So even patients on non-rebreather mask or patients who are on BiPAPs, we try to ask them, try to prone about like 12 hours if you could, and that it does help. The mechanism to improve oxygenation, recruitment of the dorsal lung regions, increasing end expiratory lung volumes, increasing chest wall elastane, and decreasing alveolar shunt, and improving tidal volume. In intubated COVID-19 patients, we recommend the prone positioning per ARDSnet if PaO2 to FiO2 less than 150. Usually we do it for 12 to 16 hours a day. In my hospital policy, I try to do it 16 hours and 8 hours of supine position. Very important. If I'm going to do the prone positioning, I have to have trained staff to deal with it. If I'm having somebody who's severely hemodynamically unstable on 3 pressures and barely maintaining his blood pressure, I'm not going to mess with the patient. I try to just leave him alone and try to, monitor him closely. We know the spinal instability, abdominal wounds, the general contraindication for prone, but particularly for, COVID patients, if you have trained staff, try to make sure all your connections are pretty secured, your ET tube, your lines and all that stuff before conducting it. Make sure the staff is trained. So if we're gonna do it, let's do it right. The other modalities, the conservative fluid management. And this is an important concept. Now, generally speaking, we try to maintain negative fluid balance in RDS patients. We don't want to be tempted too much to give Lasix in COVID patients. Yes, we need to maintain like balance input output. We don't want to overload those patients, but we need to preserve the kidneys as well. We just published this paper about the effect of the low GFR in mortality, which increased, and we're working on another paper on the albumin. So many of those patients that we notice that they do have low albumin. So we tend to give them LASIK and deplete their intravascular volume. And when the kidneys start shutting down, patients get way sicker and the mortality gets way higher. So we need to maintain at least balance or negative balance. We want to watch for the input output. We want to watch for the kidney function while maintaining the fluid management for COVID-19 patients. In terms of the neuromuscular blocker, it does facilitate the protective lung ventilation and minimize the desynchrony. It helps sometimes with the hypercapnia, but we usually try to avoid it in prolonged use. It is recommended. It does increase the risk of myopathy with concomitant steroid use because most of those patients or all of those patients should be on Decadron. So generally speaking, it's recommended to have bolus doses than drips. And if we can dip neuromuscular, don't give it more than 48 hours. There are some talks about the vasodilators. They inhaled the nitric oxide or the epoprostenol. It does have questionable benefit. So far, the Society of Critical Care Medicine recommends against routine use. I've seen people using it. They say it might work. It's still under studies. It's not definitive. ECMO, it's in severe patients. I'm not going to go into there, but we have few cases individual that might be referred to ECMO centers. It does require specialized centers. Just to mention some reports or protocols. Now, recovery study, as Dr. Khairi mentioned, it's like 6 milligrams for 10 days. In ARDS patients, it's a study from Brazil that reported higher dose of dexamethasone can improve the mortality. So they give 20 milligrams for 5 days, followed by 10 milligrams for 5 days in severe ARDS cases. So this is something to consider. Now, the big question is, would we do full or prophylactic anticoagulation? So every single hospital has their protocols. Some do, some don't, some rely on the D-dimers. At the ACCP, American Society of Chest Physicians, they had an expert panel that was published in June of this year. They do recommend the standard dose of low molecular weight heparin over the intermediate. So just the 40 milligram enoxaparin daily. And they said not superior to intermediate or full anticoagulation. To be honest, this lady, we admitted her, we got her per the panel guidelines, and she got a PE. I don't know if she got it before or she got it with us, but in September, they also at CHEST, which is basically a journal from ACCP, there was an article that suggested that standard dose prophylaxis is effective for ward patients, like which is floor patients, but maybe insufficient to prevent venous thromboembolism in ICU patients with COVID-19. This month, another study showed that it's at the Journal of American Critical Care Cardiology. It showed like therapeutic anticoagulation was associated with lower mortality than prophylactic anticoagulation, although not statistically significant. The p-value was 0.08. So to answer the questions, I'm just gonna, this is the PE that the lady has, small PE. And as I said, we don't know, that was day 5. We switched her to full anticoagulation. I'm just presenting an example protocol for Emory Healthcare, and I believe Cleveland Clinic has the same, that they put patients according to their risk levels, which I think this is a very reasonable way to classify patients, because I cannot generalize everybody needs to be on, you know, like just the low dose, because, you know, somebody who has the D-dimer of more than 3,000, let's go over those. So we have somebody who's low risk, D-dimer less than 3,000, and I think this is per nanogram per ml. Probably in Jordan there will be a conversion to it. They use the standard 0.5 per kg per day, so like the regular enoxaparin 40, 30 per day, according to the patient weight. And all the numbers per normal kidney function. So in level 2, which those are most of the ICU patients, they don't have prior history of thromboembolic disease, but their D-dimer is high. Then they use the intermediate dose, which is the 0.5 milligram per kg Q12 hours. So we give them enoxaparin, 40 milligrams Q12. If they have unexplained increased risk in the oxygen requirement, dead space, organ failure, or we have some concern for microthrombi, then we move to the therapeutic dosing, 1 milligram per kg Q12 hours. So, I mean, those are big centers. They're implementing that. I understand the rationale that initially the expert panel came up with, but new studies after that panel came by are showing increased risk of thromboembolic disease, and they recommend. So I expect that kind of panel recommendations to change shortly. Now, this lady in day 8, she got that pneumothorax, and we had to put a chest tube to expand the lung. So that will take us to the potential complications to watch for in the ICU. As I said, many patients in the ICU with COVID intubated. Interesting, we don't see like the plateau pressure of 40 or 50, but yet they get pneumothorax or pneumomediastinum pretty easily. So you have to watch for a sudden increase in the peak pressure, sudden increase in the work of breathing, asymmetry in the breathing sounds. Now, guidelines like Mass General Hospital, they don't recommend daily chest X-ray unless there's a change in the oxygenation status, but you have to watch for any of the above. So you have to watch for patients, like work of breathing, and if the patient is not doing as well, right away do chest X-ray, put that on the back of your mind. If you see the pressures are higher, the pneumothorax should be higher on your list. Thromboembolic disease, apparently if somebody is having therapeutic or like a prophylactic anticoagulation, and as we mentioned, they have increased work of breathing or unexplained, swelling, pain in their legs, we can expect thromboembolic disease. We either do like Doppler ultrasound, we do CTA, we place them on therapeutic anticoagulation. The HCAP, yes, those patients start with viral pneumonia. Indications of antibiotics are questionable, but later on, if my patients start, trending fever, like in day 8, 9, 10, if somebody starts like having secretions different in color, the tube, I'm suctioning something different, then okay, I'm probably dealing with something else. So we need to get some cultures, we need to start some antibiotics. So diffuse alveolar hemorrhage, if I see patients who are having some, bloody secretions, I'm having an X-ray, increase infiltrate bilaterally, the alveolar hemorrhage should be expected. Therefore, we have to probably increase the dose of steroids and do certain adjustment accordingly. Systemic complications, acute kidney injury, apparently shock, myocardial injury, transaminitis, pericarditis. So always we need to watch for the kidney function, watch for any changes in the volume status. Most protocols right now in most hospitals, they do recommend the CBC, complete CMP metabolic panel in cases, especially if the patient is on remdesivir or on antiviral medications. That will take me to the end, but just to let you know, in terms of the weaning, it's pretty similar to the conventional weaning. Tracheostomy for COVID patients, since Dr. Khairi mentioned that it's usually up to 20 days for severely sick patients, most hospitals, including our hospitals, we do not trach patients before 3 weeks. So there are some studies that said it's variable between 10 days and 21 days. The 3 weeks period is at least a safe period before intubating those patients. So that will take me to the end, unless somebody has any questions.
Thank you very much, Dr. Riaz, and that was an equally informative, beautiful presentation. Before we open the floor to questions, let me first welcome our distinguished panel. And we do have a quite star-studded panel from Jordan. So we have Dr. Wael Hayajneh, who's the chairman of the National Committee of Epidemics. He's a professor of pediatrics for infectious disease at Jordan University and the University of Science and Technology. Dr. Ahmed Larmouti is a consultant internal medicine and a former president of the Jordan Medical Association. Dr. Firas Hawari, who is the Chief Cancer Control Officer at King Hussein Cancer Center. Dr. Hani Jahshan, who is a forensic medicine and pathology consultant at the Bahrain Defense Force Hospital. Dr. Iyas Al Musa, who is an interventional cardiologist and an American board qualified in cardiovascular medicine. Dr. Maisa Mansour, who is a consultant of internal medicine and a specialist in thoracic and respiratory diseases. And last but not least, Dr. Maher Zghayer, who is the chairman of the Department of Pathology and Laboratory Medicine at King Hussein Cancer Center, Jordan. With that distinguished panel, I'll open the floor to everybody if they have a comment or a question. But if I may, start with a small question of my own. In my practice as a vascular surgeon, I've seen two cases, and the cases in Jordan are very limited, of first presentation of COVID being DVT. And one of them was an extensive DVT, which was followed by PE. Is that been the experience in the US with the numbers you're seeing, to both Dr. Yazan and Dr. Raed?
I can answer from my pulmonary standpoint. We have seen few cases with the very first presentation is thromboembolic disease. And it's not as common. We usually see some, at least patchy lung infiltrates on the CT scans whenever we do it. I had 1 or 2 cases myself that I've seen it. Sometimes they did have a milder form of the disease that is in, let's say, the recovery, but they still have the thromboembolic effect of the disease that might contribute to the DVT-PE. So we've seen it. It's described, but it's not as common.
Mostly I see that, and I don't know, Dr. Yazan, more in ICU patients than the less sick patients. Probably it's more common in more ill people. I've seen PE, I've seen DVT, I've seen, and as I said in my presentation, we had a 27-year-old surgical scrub tech who presented to the emergency room. And he had no past medical history with just chest pain, shortness of breath. He presented to another emergency room in town. And basically, the patient had a code blue during his ER arrival, and it was PE. And when the autopsy was done, he was COVID-19 PCR positive. So most likely he was ill, and then he presented with complication. It's not common. It's not the common presentation, but it's something to keep an eye on. It's because of its fatal outcome.
So the floor is open for questions from the panel.
I think we have a question here in the chat from Dr. Osama Khlefat. I can read it. It says, I have a question for Dr. Raed. What causes lymphopenia to happen, and is it a hallmark for COVID-19?
It's very good question. I am not sure exactly, but we see that in all viral infections, not just COVID-19. When we have anybody who comes to the hospital with Epstein-Barr virus, CMV, I have that observation where I see more lymphocyte, you end up with lymphopenia. But with COVID-19 in particular, it's astonishing. Every patient, I look at their labs, always you have to have low lymphocyte count. But I have to tell you the truth, I don't know the mechanism and the etiology of that. I don't know if one of our panelists is a hematology oncology physician. He can have
we don't have a hematologist.
Okay, that's fine. But it's well described. It is seen. I'm not sure exactly what the etiology, but I don't see it just with COVID-19. I see it with other viral infections too.
Mm-hmm.
Well, if we have no more questions from the panel, I think first we would like to thank both Dr. Yazan and Dr. Raed for the impressive presentations and for the updates as of the situation in the US, the number of cases and the complexity you're seeing, guys, definitely have lots of lessons for us here in Jordan. And we'll move to the next section of this webinar, which is the panel discussion. And I gather Dr. Ahmed Al-Armouti is going to start off by talking to us about the situation in Jordan.
مساء الخير للجميع بموضوعي أنا، وشكرا للقائمين على الجلسة الحوارية وخاصة الدكتورة سهى الغول، وشكرا للمشاركين الحقيقة اللي أبدعوا، الدكتور رائد والدكتور يزن بالمعلومات اللي زودونا فيها. الحديث أنا بدوري هو عن دور المجتمع المدني في مواجهة جائحة الكورونا، عن التجربة الأردنية. احنا بنحكي جائحة الكورونا هي عبارة عن قضية وطنية بتهم كل المواطنين، وليس لا تهم فقط القطاع الحكومي، إنما تهم القطاع الحكومي الرسمي وتهم القطاع المجتمع المدني، وبالتالي يجب أن يكون هناك مشاركة بين القطاعين أو بين الطرفين، وتأكيد مبدأ هذه التشاركية مهم، خاصة لكل طرف له دوره ولا يتعارض مع الطرف الآخر ويتناقض، بل بالعكس هو يكمل الدور الآخر. هذا الموضوع منظمات المجتمع المدني اللي بدي أخصها أنا هي بالحديث عن هي النقابات المهنية الصحية والجمعيات الأهلية والجمعيات النسوية والجمعيات الثقافية وحتى أحزابنا الوطنية بشكل عام. هلا احنا دورنا بيتمثل بجانبين، الجانب التوعوي وهذا مهم حتى نصل الى المواطن ونخلق لديه ثقة بأن ما يقال له من الجهة الرسمية هو صحيح، وأن ما يتحدث به المسؤولين عن موضوع الكورونا هو حقائق علمية صحيحة، وبالتالي يجب التجاوب مع التعليمات التي تطلب منه. وبالتالي هذا الجانب مهم، خاصة أن في قضايا مختلفة بين الكلام الرسمي والكلام وتقبل الناحية الشعبية له فيها سؤال كبير، وقد لا تكون مقبولة من المواطنين أو الثقة العالية. وبالتالي نجد في هذا الجانب ناحيتين سلبيتين: عدم التزام المواطنين في التعليمات التي للحماية الشخصية من حيث لبس الكمامة والتباعد الجسدي وغسل اليدين، وعدم البعض لغاية اليوم بيفترض أنه مرض الكورونا مرض غير حقيقي غير موجود، إنما هي قضية أخرى قد تكون مؤامرة، قد تكون سياسة والى آخره. النقطة الثالثة وهو أنه كيف نخلق هذا الثقة المتبادلة بين المواطنين وبين المسؤولين في القطاع الصحي. هذا يقع في جانبه الأساسي على المجتمع المدني، وإذا كان هذا المجتمع المدني حتى يقوم في دوره يجب أن تكون الجهة الرسمية أو الحكومة أو وزارة الصحة تثق بهذا المجتمع المدني وتعطيه مجاله، تعطيه دوره. دون ذلك بنكون إحنا كل واحد كل شخص بيغني على ليلى، وبالتالي بيحدث التناقض وعدم التناغم، ولا نستطيع أن نجد العمل المشترك في هذا المجال. هلا مجال التوعوي احنا قد موضوع مهم هو نشر الوعي الثقافي والصحي في هذا الموضوع، وأنه هذا المرض في حقائق علمية يجب أن تصل لكل مواطن. عمل وسائل توعية بوسائل التواصل الاجتماعي أو باليوتيوب أو عبارة عن مواقع الإلكترونية أو محطات التلفزة، حتى نزيد الوعي الصحي لدى المواطنين. إجراء مقابلات، يجب أن يتم إجراء مقابلات مع مرضى تم شفائهم بالصوت والصورة، أو بالصوت مع ذكر التفاصيل التي عاشوا فيها، حتى نخلق نوع من الطمأنينة للمواطنين ونضع ثقة أن هذا المرض موجود في أردننا. والعمل على حماية المريض في خاصة الذي يصاب في مرض الكورونا من حالة التنمر والإساءة له وكأنه الإصابة بمرض الكورونا هو وصمة عار أو جريمة أخلاقية يرتكبها المصاب. الجانب الميداني يجب، وإحنا قد إذا بدنا نأخذ التجربة الأردنية في نقابة الأطباء كمثال ونقابة الصيادلة ونقابة أطباء الأسنان في الأردن، تم تشكيل فرق. كان عندنا فرق لجنة طوارئ في نقابة الأطباء، تم تشكيل لجنة اسمها فزعة وطن شاركت بالاستقصاء الوبائي من خلال تشكيل مجموعة كبيرة من فرق الاستقصاء، وساهمت بجهد تطوعي غير مدفوع الثمن وغير مدفوع الأجر على مدى الفترة الماضية، وساهمت باستقصاء الحالات الوبائية. كان لهم تجربة ناجحة ورائدة في منطقة شمال المملكة الأردنية الهاشمية. قاموا بتشكيل فرق أخرى لتوزيع العلاجات في فترة الحظر التي استمرت لمدة أسبوعين، وهذه التوزيع حوالي فوق إذا ما خانتني الذاكرة 300,000 أو 250,000 وصفة طبية خلال 15 يوم أو 20 يوم استطاعوا توزيعها على كل المرضى المزمنين من خلال مرضى سواء الجامعة أو وزارة الصحة، وأعتقد بعض حالات مرضى الخدمات الطبية الملكية بجهد شخصي وبجهد يعني ذاتي. وكمان هم تابعوا المرضى اللي في مناطق العزل في بداية العزل، وزاروا المناطق اللي كان فيها عزل وأخذوا معلومات من المرضى وكيفية الإصابة وعملوا جدول لهذا الموضوع. كما قاموا بجمع تبرعات طبية وعينية تم توزيعها على المواطنين الأردنيين. كما قاموا بمتابعة المرضى المزمنين في بيوتهم، وشكلوا فرق صحية للمرضى الذين أجريت لهم عمليات جراحية وبحاجة لمتابعة في البيت، ثم بعض المرضى الذين بحاجة لعمل جراحي بسيط في المنزل. قاموا بهذا الفترة وشكلوا فريق صحي جراحي على المناطق اللي بحاجة إلها، وكانوا يزوروا هذا المرضى. كما شاركوا في موضوع أنه فكرة أن يكون طبيب في كل سيارة دفاع مدني، وهذه أثبتت فاعلية جيدة جدا، بحيث أن كل إنسان أو كل مريض يتصل بالدفاع المدني يذهب مع سيارة الإسعاف أو فريق الدفاع المدني، يذهب طبيب يقيم الحالة في المنزل في مكانها من دون تحريكها، قد يتم علاجها وإعطاء العلاج الموضعي أو الجراحي أو خلال حقن أو توصيف الحالة، ومعالجة حوالي فوق 75% من الحالات كانت تتم معالجتها في البيت من دون حاجة لنقلها للطوارئ. وهذا مما خفف كثيرا عن الضغط على الطوارئ في المستشفيات، خاصة مستشفى البشير والمستشفيات وزارة الصحة الأخرى. هذه التجربة تستدعي منا جميعا أن نفكر بعمل تنظيم المجتمع بهذا الفرق بهذا الطريق، خاصة في حدوث الأزمات، سواء أزمة مرضية صحية كمرض الكورونا أو أزمات مجتمعية أخرى. كما ممكن أن نشكل مرة أخرى لجان في الأحياء، يعني كل حي من الأحياء كل 100,000 كل 150,000 منطقة يشكل فيها لجنة تتابع كل السكان، ما عندها معلوماتها، عندهم أشخاصها، عندهم تلفونات، كيفية التواصل معها، ويمكن تلبية حاجاتهم في هذا المجال. هذه تجربة سريعة، هذه رؤوس أقلام حول موضوع كيف دور المجتمع المدني في هذا الموضوع. مثلا لو أخذنا نقابة المحامين، يجب أن تدافع في هذا المجال عن حقوق العمال المياومة اليومية التي انقطع دخلهم خلال هذه الفترة، أو الموظفين العاملين في القطاع الخاص الذين تأثر دخلهم بشكل كبير خلال فترة الحظر التي استمرت حوالي شهر زمان على شكل متقطع أو أكثر من شهر. وبالتالي هناك نقابة الصيادلة تستطيع توفير كثير من الأدوية والمستلزمات الطبية كتبرع لمساعدة المرضى وذوي. نقابة الأسنان أقامت عيادتين للطوارئ في مجمع النقابات ولمعالجة مرضى الأسنان الذين كانت السبل مغلقة أمامهم، لا يوجد طوارئ ولا يوجد عيادات أسنان، وبالتالي كان لابد من فتحها. لكن للأسف تم فهم هذا الموضوع بطريقة غير واقعية وغير سليمة. تم إيقاف هذا العمل المدني الذي يمثل مشاركة شعبية بقرار من وزير الصحة السابق. وبالتالي أنا بعتقد أن دور المجتمع المدني دور أساسي وثابت، ويجب تعزيزه بالمشاركة مع النشاط الرسمي حتى تكتمل الصورة، وحتى كل منا يساهم في المجال الذي يستطيع فيه حتى نواجه هذا الوباء وهذا الجهل. شكرا لكم جميعا.
شكرا دكتور أحمد على هذا التداخل الجميل عن دور المجتمع المدني. واحنا we're lucky انه كمان to have amongst the panelists الدكتور وائل هياجنة اللي هو مسؤول ملف الكورونا حاليا بوزارة الصحة. دكتور وائل، إذا نقدر يعني ناخذ الفائدة من مشاركتك بهذا الموضوع، هل الوضع الوبائي حاليا عندنا بالأردن وخاصة اليوم إنه في 2800 حالة بوزيتيف و38 death on the trend upwards or is it getting a lot worse؟
شكرا جزيلا. السلام عليكم. أولا اسمح لي بأن أشكر المتحدثين الكرام. أنا يعني أعتذر، يعني لم أستطع أن أستمع إلى المحاضرتين بشكل كامل بسبب المشاغل المعينة، ولكن حاولت أن أستفيد قدر الإمكان. وأشكر الدكتورة سهى الغول على إتاحة المجال لي بأن أكون معكم. الوضع الوبائي مقلق، ولكننا لسنا على حافة انهيار. يعني أستطيع أن أشرح بعض القدرات الصحية الموجودة لدينا الآن بشكل صريح وواضح وشفاف. نحن لدينا في الجهاز الصحي الأردني تقريبا 1300 غرفة، 1300 سرير مخصصة لمرضى كورونا الذين لا يحتاجون إلى العناية الحثيثة. لا يحتاجون إلى العناية الحثيثة، يعني COVID-19 designated beds. في عندنا أيضا 700 سرير ICU، 700 سرير ICU designated for COVID-19. ولدينا أيضا 600 تقريبا 600 conventional ventilators plus other devices for non-invasive ventilation which we are trying to get more of them. إذا بتلاحظوا الأعداد قد تبدو أنها تزيد، وهي تزيد، لكن خليني أحكي لكم أنه إحنا في الأيام القليلة الماضية نقوم بعملية انتقال جوهرية من الرصد الورقي وإدخال البيانات بشكل متنقل إلى عملية إدخال إلكتروني كاملة. يعني قبل أسبوع تقريبا كانت الأمور، كان عندنا لو قلنا 24,000 فحص في اليوم، 10 ل 11,000 بيكونوا مسجلين إلكترونيا، و13,000 يتم نقلهم ورقيا أو بطرق يعني إكسل شيتس وما شابه ذلك. اليوم 22,000 فحص من مجموع الفحوص التي أجريت تم إدخالها عن طريق عملية رصد إلكتروني تم تصميمها خصيصا من لحظة الانتري بوينت. يعني أي مريض في أي مستشفى وفي أي مركز صحي وفي أي كرفان وفي أي موقع في الأردن، نتيجته الآن لازم يتم تدخيلها إلكترونيا من نقطة الصفر. وإذا طلعت النتيجة اليوم بتروح للمريض مسج سواء كان بوزيتيف أو نيجاتيف. هذه لأنه إحنا مشكلتنا في الأردن يعني بدي ألخصها بثلاث أمور. مشكلة الرصد الوبائي الذي كان يتأخر لأيام حتى نصل للمخالط لكلوز كونتاكت كانت تأخذنا 3 ل 4 أيام، وحتى تطلع النتيجة كمان 2 to 4 days، ففي عندنا 6 to 7 days delay. وأنتم طبعا بتعرفوا what does it mean to keep someone who is COVID-19 positive يعني free in the community. بنحاول احنا الهدف المعقول اللي بنحاول نوصل له اليوم to decrease this period to 48 hours maybe 72 hours. بدناش نحط احنا اهداف يعني خياليه لا نستطيع ان نصلها. الطريق مليء بالهفوات والثغرات. نحن الان مثل ما حكى يعني نقيبنا السابق الدكتور العرموطي بنحاول نستفيد من قوى المجتمع المدني. لدينا مخزون كبير هذه الايام من المتطوعين، ونبني قدراتنا الذاتيه في وزاره الصحه المرهقه اصلا. قد تكون زيادة الحالات مرتبطة بهذه العملية هذه الأيام، لكن على الأقل الحالات لا تتضاعف يا أخوان. قبل عدة أسابيع كانت الحالات تتضاعف، أسبوع 2 3 4 كانت at least doubling every week. We're not having this these days. تنسوش إنه هذول mortalities what are we dealing with today are they يعني reflect previous infections يعني 10 to 14 days ago. الوضع يجب أن نكون متوجسين ولكننا بنفس الوقت متفائلون. يعني بصراحة كمان إذا أول قضية الرصد الوبائي، القضية الثانية قضية الكيس مانجمنت اللي عمالكم أنتم بتشاركوا فيها بشكل عظيم اليوم. كيس مانجمنت أوف كيسز هاي كمان قضية، لأنه إحنا أصلا الموارد البشرية الموجودة عندنا لما تصل للسب سبيشالست موارد محدودة. والقضية الثالثة الجفرنانس، يعني how can you connect all these things together. وفي قضية مهمة جدا بناش يعني أدخل فيها أنا بشكل اللي هي قضية كيف نحمي كوادرنا الصحية، لأن كوادرنا الصحية يعني مهمة جدا أن تكون محمية أقصى درجات الحماية، لأنهم إذا نهار معنا النظام الصحي. الوضع كما ذكرت يعني ما بديش أطيل عليكم، وأشكركم مرة ثانية. نحن نرحب بكل عمل قد يساهم في الكيس مانجمنت اللي بتحكوا عنه اليوم، قد يساهم في تقديم telemedicine experiences and follow up from those Jordanian around the world. والله يحمي البلد، شو بدي أقول أكثر من هيك.
الله يحمي الجميع إن شاء الله. Thank you Dr. Wael. This is a great update. وإحنا we're hopeful إن شاء الله بأيدي أمينة as epidemic management. However, في anticipated curves اللي published من states would anticipate إنه a country in the size of Jordan with the current numbers we're seeing, we should be seeing cases in the number of 5,000 a day not far from now. Do we have the ability as a healthcare system to deal with it if we get that?
يعني أعطيتك القدرات الصحية تاعتنا. إحنا الموديلنج اللي بنعمله يعني لكل 1000 حالة تقريبا بدك 150 فنتليترز تقريبا، يعني كل 1000 حالة بتدخل المستشفى ديلي، يعني بتشخص ديلي. كل 1000 حالة بتشخصها ديلي. You need almost 150 bed in a point of prevalence على أي وقت، لأن على حساب إنه 10 أيام يمضي المريض على الاي سي يو. بالاي سي يو نحن حاسبين 6 أيام للريجولار بيد و10 أيام للاي سي يو. إذا وصلنا لرقم 400 سرير ل 500 ice ventilators and I think we will be hitting a red zone area. طبعا هذا بيختلف. احنا مشكلتنا دكتور مش بالاي سي يو بيد actually ولا بالفنتليترز، مشكلتنا بالريجولار رومز. الريجولار رومز بدك تحط فيها اكسجين واي في فلويدز and this. So urgently we are trying to upgrade our regular beds capacity. We have different ways to do it. We are trying either renting hospitals or upgrading already used hospitals, or using some institutions that are not hospitals, but we can transform them into some types of hospital. We might do hybrid of these things. So, and in the last few days, maybe we managed to increase our capacity by a few hundred beds. يعني إحنا نمشي على حقل مليء بالآلام والآمال إن شاء الله.
إن شاء الله. We do have Dr. Firas amongst our paralysts as well, and I would like to hear your input, to be honest, in that aspect, Dr. Firas.
مساء الخير جميعا. شكرا دكتورة سهى، دكتور مأمون، المنظمين، السبيكرز والبانلست. يمكن عبر السنوات اللي عشناها كلنا، الجيل تبعنا، شاهدنا كل المؤسسات الصحية الدولية دائما بتركز على موضوع الوقاية، الكشف المبكر، المطاعيم، المضادات الحيوية. لأول مرة في تاريخنا الطبي المعاصر، واللي يعني أنا من تاريخ دخولي إلى كلية الطب وحتى اليوم، لأول مرة يجبرنا مرض ويجبر هذه المؤسسات اللي اعتادت على العمل خارج المستشفيات إلى الدخول إلى داخل المستشفيات وإلى قلبها، وهو الانتنسيف كير. وهذه الجائحة اليوم كشفت عن عدم جهوزية النظام الصحي العالمي بشكل عام، والنظام الصحي في الدول النامية بشكل خاص. وإذا لاحظنا أنه ضعف أو عدم استعداد النظام الصحي من حيث الكريتيكال كير والخدمة داخل المستشفيات كان سبب رئيسي في توجه بعض الدول إلى عملية الحظر الشامل، بينما استطاعت الدول الكبرى واللي عندها نظام صحي أضخم تفادي إلى حد ما اللجوء هذا الخيار اللي هو صعب جدا، واستطاعت أنها تستوعب الصدمة. أكبر دولة طبعا مستعدة في هذا المجال اللي هي أمريكا، وكنا بيعرف هذا الكلام. حدث في بعض الولايات، في بعض المدن اللي هي اضطرت أنها تلجأ، لكن في النهاية يعني إذا ننظر الآن سبب كبير اليوم في تحديد توجه أي دولة باتجاه الحظر الشامل أو عدم التوجه الدولي للحظر الشامل هو وجود قدرة على استيعاب أعداد كبيرة من المرضى وامتصاص الضربة الأولى من هذا الفيروس. النقطة الثانية، كشفت أيضا هذه الأزمة عن قلة الخبرة. يعني إحنا يعني معتادين أن تأتي حالات إلى غرف العناية المركزة مصابة بأمراض صعبة، ال ARDS على وجه التحديد، لكن لا تأتي بهذه الكثرة. فبالتالي إذا بنلاحظ اليوم فرق الوفيات في الموجة الأولى مقارنة في الموجة الثانية في كل دول العالم اللي حدثت عندها موجة أولى، في اليوم اتجاه واضح بنزول في عدد الوفيات في الموجة الثانية مقارنة بالموجة الأولى، مع أنه التسارع في أعداد الموجة الثانية اليوم في بعض الدول كان أشد. وهذا بيدل على أنه استغلت هذه الدول الموجة الأولى لتحضير وحدات العناية المركزة والسياسات للعمل داخل المستشفيات المتعلقة بالعلاج، بالوقاية، حماية القطاع الطبي، توفير الخدمات اللي كانت ناقصة أصلاً. يعني اليوم المواطن الأردني لأول مرة وحتى في العالم أصبح يسمع عن جهاز التنفس الاصطناعي، أنواع التنفس أو إيصال الأكسجين، بيسمع عن الصور الشعاعية وبيسمع عن فحوص محددة، لكن أهم ما سمع فيه المواطن الأردني اليوم حقيقة، واللي لا يزال غائب عندنا في الأردن، وهذا الشيء مؤلم أنا بحكيه بكل صراحة اليوم، هو مفهوم العناية الحديثة القائمة على الفرق متعددة التخصصات يقودها أخصائي العناية الحديثة، ولكن فيها المعالج التنفسي، فيها الصيدلاني السريري، فيها الممرض المختص في الICU وغيره من هذه الفرق اللي اليوم أثبتت هذه الجائحة أنه لا يوجد دواء شافي لهذا الفيروس، وفقط العناية الحثيثة بمفهومها الحديث المتوازن اللي بيحدد الأهداف وينظر إلى أدق التفاصيل هو الذي سيحدث الفرق. لذلك إذا ما أردنا اليوم خفض نسب الوفيات في الأردن في العناية المركزة، لن يحدث هذا الكلام عن طريق توفير جهاز تنفس اصطناعي ووصله إلى مريض، أو عن طريق توفير فضاء يوضع فيه سرير. ولذلك ستكون للأسف تجربتنا مؤلمة في هذه الفترة، إلا إذا استطعنا اليوم وبما هو موجود من قدرات محلية تأسيس فرق وسريعا حتى تشرف على المبادئ الأساسية في العناية المركزة. هي مش اختراع صاروخ، لكن يجب تقديمها وبشكل مركز وبشكل مكثف يوميا وعلى مدار الساعة من خلال هذه الفرق المختصة حتى نحدث الفرق. لا يوجد دواء اليوم، لا يوجد لقاح اليوم، ولن يظهر شيء على الساحة حتى يخفض نسب الوفيات بسرعة. يعني أتمنى أنه ما أكون متشائم، لكن إذا ما إحنا اليوم تحركنا سريعا سنستمر في تسجيل الوفيات، مع أنه النظرة إلى الوفيات عندنا في الأردن يجب أن تكون مختلفة، وما هو مقبول خارجيا غير مقبول محليا، لسبب معدل عمر الوفاة في إيطاليا كان 80 عاما، في الأردن اليوم من يدخل إلى ICU هو قطعا أقل عمرا من الداخل إلى ICU في أمريكا أو في إيطاليا. ونقطة مهمة اليوم يمكن في المحاضرة الأولى كان risk factors. في آخر تعديل الريسك فاكتورز تم إنزال الأزمة إلى المواقع المتوسطة من حيث الاختطار، لكن بالتأكيد كان وضع التدخين في القائمة العليا اللي فيها جميع الأمراض المناعية والأوبيزيتي زائد السموكينج. وإحنا اليوم مصنفين كدولة الدولة رقم 1 في العالم من حيث التدخين، وأيضا من حيث عدد السجائر اللي بدخنها الفرد. وإحنا شفنا أثر هذا التدخين على مرضانا في مركز الحسين للسرطان، يزيد من احتمالية الدخول إلى ICU واحتمالية الوفاة. ما بدي أطيل عليكم، أتمنى أنه نمشي بسرعة باتجاه تأسيس هذه الفرق المتخصصة من الجهود الموجودة، وشكرا للجميع مرة أخرى.
شكرا دكتور فراس. يعني التداخل بموضوع العناية بالحثيثة وخاصة النيد فور ات is obvious من get go. It seems إنه إحنا لسه بالموجة الأولى، يعني we haven't gone into the second wave لأنه we delayed الموجة الأولى. If I may ask Dr. Hani Jahshan, who's been an observer, who's in Bahrain, وبحرين had quite a موجة أولى in a big sense ومصنفة حاليا بالنسبة للأردن من الدول الحمراء. What's been his observation or experience في هذا الموضوع؟ دكتور هاني. Do we have دكتور هاني؟
تسمعني الآن؟
Yes. تفضل دكتور هاني.
يا بشرفني أن أكون معكم، وشكرا لك دكتور مأمون وللدكتورة سهى وللضيوف اللي شرفونا من أمريكا، وكانت محاضرات بالفعل رائعة. طبعا زي ما بتعرف أنا حاليا بقوة دفاع البحرين كمستشار بالطب الشرعي للقضاء العسكري، وخبرتي في الأردن كانت لغاية 2013. وطبعا الوضع بالتعامل عن دور الطب الشرعي، الفكرة الأساسية اللي كانت عندي اللي بدي أشاركها معكم عن دور الطب الشرعي بالتعامل مع هذه الأوبئة، خاصة بعد الضجة اللي صارت عن كيف دفن الوفيات وشو دور الطب الشرعي بدفن الوفيات وبأوضاع القبور، وهل هناك يعني في ضرورة لوضع اسمنت وشيد إلى آخره. طبعا الشيء اللي بدي أحكيه إنه من لحظة الوفاة بالمستشفى لنقل الجثة إلى مشرحة المستشفى ثم لنقلها إلى مشرحة الطب الشرعي، وما عرفت ليش هذا الإجراء يعني. بعدين لدفنها من قبل الطب الشرعي كان هناك في يعني موضوع كله خارج نطاق تخصص الطب الشرعي. زي ما نعرف الطب الشرعي هو بأمر القضاء بيكشف على الحالات القضائية، وبعض حالات الكوفيد قد تكون قضائية مثل الوفاة الفجأة، وبعض الحالات اللي قد ترافقها أخطاء طبية أو حتى جرائم مرافقة لشخص مصاب البوزيتيف كوفيد. فالفكرة كانت إنه هذا مش من اختصاص الطب الشرعي، هذا من اختصاص وزارة الصحة. دور الطب الشرعي محدود في فقرة محددة هي بالكشف القضائي على الحالات، وليس بالتعامل مع جميع حالات الوفيات من كوفيد، وهذا طبعا حسب قانون الصحة العامة مادة 22. المثل اللي بدي أعطيه للمقارنة بالبحرين هون، إنه أي وفاة تحصل في أي مكان في البحرين يتوجه فريق من وزارة الصحة، ما له علاقة بالطب الشرعي، يتوجه فريق من وزارة الصحة مختصين بالببليك هيلث، ومعهم يعني دعم من الدفاع المدني، وبنقلوا الجثة مباشرة إذا ما كانت قضائية إلى الدفن. عفوا. وطبعا هذا يعني كنت أتمنى أنه هذا الشيء يصير بالأردن، لأنه مجرد نقل الجثة وتحريكها والتعرض إلى الإفرازات اللي بتخرج منها بيكون هناك في مجال كبير للعدوى. النقطة الثانية اللي حبيت أركز عليها واللي هي أنه بلحظة الوفاة يموت الفيروس، وهذا طبعا الحكي مش صحيح أبدا. واستغربت أنه يعني صدر قرار انه يعني من جمعيه الطب الشرعي مثلا انه باللحظه اللي صارت فيها الوفاه الفيروس يموت اوتوماتيكيا، وهذا الحكي مش صحيح. في فرق بين الوفاه السريريه اللي هي التوقف الغير منعكس للجهاز الدوري والجهاز التنفسي والجهاز العصبي المركزي، هاي كلينيكال ديث، لكن في شيء اللي بيستمر بعد هذا الموضوع اللي هو السيلولار ديث. السيلولار ديث ممكن يكون في قرنية العين لمثلا 48 ساعة، وزي ما تتذكروا يعني كان يجرى إجراء زراعة الكلى خلال نص ساعة لساعة من الوفاة، بمعنى إنه الخلايا حية، وهي بيسموها الحياة الخلوية. ففي فرق بين الحياة السريرية والحياة الخلوية أو الموت الخلوي اللي هي فترة الحياة الخلوية. خلال الحياة الخلوية ثبت في عدة دراسات راجعتها إنه إذا أخذنا إفرازات من جسم الشخص اللي شخص إنه كفد أثناء الحياة لمدة يومين ثلاث، يعني هناك وثائق أو دراسات أجريت إنه راح تكون بوزيتيف لمدة يومين أو ثلاث، وأجري تجارب على الطيور والحيوانات الأخرى، وتبين إنه الفيروس بظل بالجثة بعد الوفاة حسب ظروف الانفايرمنت ممكن يظل لأسبوعين. بس الأفرج بالآخر دراسة أجريت بأستاذ طب شرعي بجامعة مونتسير في تونس، وأخذ عينات من الوفيات الموجود عنده من إفرازات الجسم، وكانت بوزيتيف للبي سي ار بوزيتيف. طبعا يعني هذا دليل انه بلحظه الوفاه ممكن يظل الفيروس لفتره فتره. فنقل الجثه من مكان الوفاه باي مستشفى خاص يجب ان يتم مباشره الى مكان الدفن. الموضوع الاخر بدي احكي عنه هو اجراء التشريح بالطب الشرعي لحالات المثبت انها كوفيد. هذا خطر بديش احكي يعني مرعب، لكنه كامن، ويجب ان يتم بغرف تشريح مجهزه حسب البايو هازارد 3، وهي لها مواصفات معينه تتكون من 3 حجر، غرفه غير معقمه لغرفه شبه معقمه لغرفه يعني ملوثه، وبدخل فيها الطبيب وبيخرج بالعكس بمسار اخر. وطبعا لازم غير الاجهزه المتوفره بالمشرحه من ضغط سلبي وفنتيليشن بمسار واحد زي الفنتيليشن تبع الطائرات. وبصراحه لا يوجد بالعالم العربي اي مشرحه مجهزه لاجراء التشريح بهذه الطريقه. فاذا تم التشريح بالبشير او بمستشفى الجامعه بجرأه زياده، يعني من الناحيه العلميه احنا بنحط الاطباء هذول تحت خطر، وهذا يعني منشور ما بده اي يعني المراجع اوريدي متوفر. الشيء الاخير اللي بدي احكي عنه اذا ممكن اشارك السلايد، هو وصار في جدل مبين الصوره عندكم.
دكتور لازم تعمل سكرين شير سكرين بالاخضر، بس اضغط على شير سكرين. ايوه
شايفينها؟
اوكي بس ابدا افتحها دكتور. شايفين السكرين؟ بس لو تضغط على ايوه هلا شايفينها.
اوكي. اللي هو ببساطه انا استغربت الفوضى انه هذا مات من كوفيد ولا مات من مرض ثاني. وبعدين منظمة الصحة العالمية حطت ستاندرد موضوع وحطت updated international classification of diseases ونشرته، حدث آخر شيء بشهر 9. فيعني التسلسل المفروض يكون هذا، وأنا متأكد إنه أغلب التباليغ اللي على الوفاة اللي عم بتتم ما عم بتتم بالطريقة هاي اللي هو ABC. والجزء الثاني الجزء يعني كوفيد لازم يظهر بالمرحله الثالثه اللي بيؤدي اكيوت ريسبيراتوري ديس سيندروم واللي ناتجه عن نمونيا الناتجه عن سسبكتد كوفيد 19. طبعا اذا الاكومبانيد كونديشنز كوروناري هارت ديزيز ازمه اي شيء اخر هذا لازم ينوضع هنا. بس هاي الحاله تصنف زي ما بنصنفها بالبحرين، هاي الحاله تصنف انها كوفيد طبعا لانه ظاهر جدا انه باخر يعني يوم او يومين قبل الوفاه دخل باكيوت ريسبيراتوري ديستريس سيندروم. هاي بتختلف عن حاله ثانيه انه شخص انه عنده مايوكارديال انفاركشن وبالصدفه ظهر انه عنده كوفيد بوزيتيف. فبالحاله هاي لازم يتصنف انه مش كوفيد، لازم يتصنف انه مايوكارديال انفاركشن. وطبعا كلها بتعتمد على الكلينيكال ايفالويشن وقدرات الطبيب المعالج بانه يقدر يفصل منهم. بس اللي انا سمعت انه عم بيصير وبجوز في اكثر من دوله عربيه انه كل هاي الحالات ما دام طلع كوفيد بوزيتيف عم يصنف انها وفاه كوفيد، وهاي بترفع حالات الوفيات بشكل كبير. حتى حالات اللي بنروح عليها على مسرح الوفاه وفاه فجاه، وطبعا لانه ما فيش تشريح بناخذ مسحه من الانف بيطلع بوزيتيف، الحالات هاي ايضا تسجل انها كوفيد ناتجه عن من حالات كوفيد. وبنفس الوقت بالواقع هي ممكن انه يكون مات من اي شيء اخر. الحال طبعا بندخل في متاهه هل نجري التشريح او لا. طبعا يعني زي ما حكيت بالوضع الحالي اصلا منظمه الصحه العالميه يعني لا توصي بالتشريح الا بالحالات القضائيه الواضحه. هاي هي يعني الموضوعين اللي حبيت اشاركهم معكم بالحاح اللي هو التصنيف International Classification of Diseases اللي خاص بكوفيد، والموضوع الثاني نقل الجثة والدفن انه ليس من اختصاص. طبعا الكود اللي مستخدم هو U0702 او 01 اذا كانت الحالة مشخصة بالمختبر، و02 اذا كانت الحالة مش مشخصة بالمختبر. حتى بالاحصاءات يبين إذا الطبيب شخص كلينيكالي لسبب أو آخر ما قدرنا نعمل التست فهي تبقى حالة كوفيد إذا كان الطبيب المعالج يعني عنده قناعة إنها حالة بوزيتيف، وبالتالي بنقدر نميز بينهم بين تو كاتيجوريز. والكاتيجوريز الأهم الحالات اللي ماتت من أمراض مزمنة وكانت بوزيتيف لازم تنفصل لحالها، ولازم المجتمع يفهم من قبل وزارة الصحة وليس من الطب الشرعي. هي مسؤولية بس بابليك هيلث، والمادة 22 قانون الصحة العامة يعني ألزمتها لوزارة الصحة يميز بين الثري كاتيجوريز هدول: وفاة ناجعة عن كوفيد، وفاة ناجعة عن كوفيد يرافقها مرض ولكن سبب الوفاة هو كوفيد، والحالات والمجموعة الثالثة أمراض أدت إلى الوفاة لكنها هي كوفيد بوزيتيف، حتى تكون الإحصائيات بالفعل تعكس الواقع، وحتى نريح الناس من الفوضى اللي صارت. انا مريضي مش كوفيد مات من القلب والقصص كلها. شكرا دكتوره سهى، شكرا دكتور مأمون، وانا يعني انبسطت اني اكون معكم.
شكرا دكتور هاني. It's a pleasure. وبالعكس احنا بهذا nice thing about this epidemic, well there's nothing nice about an epidemic, بس unusual about it انه في so many topics they come apparent لانه this is a new disease واحنا زينا زي العالم we're discovering lots of things about it. We're nearing the time of closure. فأنا on my behalf I thank both speakers for their amazing talks and the distinguished panelists and for the opportunity to be part of this. And I'll get back لدكتور Gul for closure.
شكرا للجميع على هذا وجودكم معنا، وإن شاء الله راح تكون هاي بداية لنشاطات ثانية يمكن تاخذ أشكال مختلفة. زي ما حكى الجميع إنه هاي، وزي ما حكى ركز الدكتور أحمد إنه هاي علينا مسؤولية إحنا كمجتمع، إحنا كأطباء جزء من المجتمع، والمجتمع ككل لازم يتعاون عشان نقدر نتخطى هاي الجائحة. وما بدي اطول عليكم كثير. احنا على كل حال في ايميلات رح اكتبه هلا بالتشات قبل ما اخلص، وفي على موقع المبادره على صحه وطن في بتقدروا تبعتوا اي حدا عنده اسئله بيقدر يبعث مسجز واحنا بنوصلها. اذا اي حدا من الاطباء حاب يتواصل مع الجيست سبيكرز احنا ممكن كمان نوفر هذا الشيء. وزي ما حكيت ان شاء الله هاي بتكون بدايه شيء كويس، واحنا بنتمنى انه الجميع يعملوا على هذه الاشياء. وشكرا للجميع.